Alrighty, so this is the last slideshow for week 11. We're doing gastrointestinal. So lots of things in the GI system. I've listed them all here, and we're going to talk about each one as we go through. GERD and Barrett's esophagus. So GERD is basically when there's a decrease in lower esophageal sphincter tone. You have the acid coming up. Usually you get a sensation of pain or discomfort. It's pretty rare, actually, that the acid gets all the way up in the back of the throat anymore. That sensation is called water brash, where you actually taste the acid. Again, that's uncommon because as soon as people start having these sensations, they usually take a medication that's either a histamine 2 blocker like Pepcid or Zantac, or a proton pump inhibitor like Prevacid or Prilosec or one of those. If, in fact, you have chronic acid in that lower esophageal area, the cells will actually change from esophageal cells into stomach cells. When one type of cell turns into another type of cell, we call that metaplasia. It's not a cancer, but it can actually increase the risk of a cancer. And so we worry about that. When that happens, that's called Barrett's esophagus. And we tend to put those people on PPIs for the rest of their life. We don't really see a whole lot of side effects, and the potential avoidance of cancer is felt to be worth whatever side effects might happen with the PPIs. Peptic ulcer disease and H. pylori. Peptic, by definition, is any area of the GI tract that secretes pepsin. Usually that's the stomach and the duodenum primarily, and so a stomach ulcer or a duodenal ulcer, both are considered to be peptic ulcers. The stomach, of course, is very acidic. The duodenum is actually pretty basic, which is really interesting. It has a very high pH. We know that H. pylori is definitely associated with ulcers. I don't think that it's as commonly associated as we think because we rarely see actual ulcers anymore. We usually see irritation, but to actually ulcerate all the way through the top layer of the stomach into that muscular layer, pretty unusual. We decrease the acid. So yes, if something has ulcerated all the way through, the odds are that it is something like H. pylori, but we don't see that particularly often. H. pylori is related to Campylobacter, and that's why you'll sometimes see that when they do an EGD, they'll do a CLO test, a CLO test. CLO stands for Campylobacter-like organism, and so if that CLO is positive, we assume that that's H. pylori, and we put them on usually triple drug therapy to get rid of it. Irritable bowel syndrome. So irritable bowel syndrome is alternating constipation or diarrhea. Sometimes there's a predominance of one over the other. It usually requires that other more serious things be ruled out. A lot of people say they have a nervous stomach. They'll have constipation or diarrhea. You'll see the abbreviations IBS-D and IBS-C used for diarrhea or constipation. We'll give anticholinergic medicines like Levsin or Donatol to slow down the gut if it's a diarrhea type. And so anticholinergics, do slow down the gut. Cholinergics would stimulate the gut. Anticholinergics will also speed up the heart because cholinergics would slow the heart. Something else that has come out fairly recently is something called the FODMAP diet, FODMAP. I tell patients it stands for fermentable oligo, mono, and polyenes. That's a very simplification of the actual what it means. But all of those things are types of sugars. There are people that if you put them on this FODMAP diet, about 50% of the patients that I have with IBS get substantial improvement. So it is actually pretty good. Now, not everybody obviously responds, but 50% ain't bad when previously you had a condition that you didn't get much response at all. The GI doctors do a lot of the IBS-Cs and the IBS-D medications. All of those medicines tend to be pretty pricey, so I don't do a whole lot of them. So IBD, which is inflammatory bowel disease, is totally different than IBS. So inflammatory bowel disease are usually Crohn's and ulcerative colitis. Note that this is the correct spelling of Crohn's. Everybody wants to spell it like it's a chronic illness, and so they'll spell it CHR. That is incorrect. Crohn's and ulcerative colitis are both autoimmune. TNF-alpha blockade will really decrease the symptoms. They're very inflammatory. Crohn's causes a lot of mucousy and bloody stools. Ulcerative colitis more just bloody. Ulcerative colitis only involves the large bowel. So removing the large bowel, doing a total colectomy, is curative for ulcerative colitis. Now, Crohn's, on the other hand, can affect the small bowel, large bowel, or both, and it's usually about a third. Some are just small bowel, some are just large bowel, some are both. It can actually affect all the GI tracts, so some of those folks will even get lesions in their mouth. People with ulcerative colitis usually get kind of continuous lesions. People with Crohn's disease will get what they call skip lesions, where they have a little area, then it skips some of the colon or bowel, another area, so on and so forth. Treatments, you can use anti-inflammatories like mesalamine, those kinds of things. But if it's substantial, usually people are put on monoclonal antibody type medicines at this point. So this slide is just to remind us that there is a lot of neural innervation to the gut. The upper part of the gut is usually innervated by the vagus nerve. We talk about vagal stimulation from a rectal exam. In fact, that's really more the pelvic nerves that are affected as opposed to the vagus nerves, which are cranial nerves, right? So this is, spinal. The middle, the thoracic and the that portion, even the cervical, are more likely to be sympathetic stimulation. So stimulation here results in effects here, lots of innervation. Stimulation here also affects the cord, and the cord feeds back to the brain. So the gut is very closely related to what's going on in the brain. Diverticulitis, diverticulosis is just the condition of having out pockets. You'll have the colon and then there'll be a pouching out. We used to think that seeds and things got caught in there. The surgeons will tell you they never find seeds in there, and they really dispute that. Some of those foods, though, do bother people, like tomatoes or whatever. It's usually because they're high fiber, we think. We don't think it's the actual seeds, but you will see people that are still trying to avoid seeds, but the general feeling is it's probably not important. Once an area gets inflamed, you start getting infection around it. Then you have diverticulitis, much more painful, usually a high white count, usually a very tender belly. Usually we can knock those down with antibiotics, usually a combination of a quinolone or a sulfa drug and a something like Flagyl, metronidazole, which is hits the anaerobics and also has some antifungal effect. We worry that these areas can actually perforate a little bit. You can have a ruptured tick. You can actually develop a fistula, but usually people seek out treatment, and it's pretty rare that those happen nowadays. Celiac disease. Everybody and their brother is worried about gluten now. Celiac is a very specific immune process in which there is permanent damage to the intestine if the person eats gluten. It's not just somebody who is gluten intolerant, has some stomach aches, has problems. That's a very different thing. We do antibody testing to see if they do have antibodies to the gluten. There's actually genetic markers, the human leukocyte antigens, number DQ2 and DQ8. You tend to have one or the other or both to truly have celiac disease. If you have neither one, it essentially rules it out. Not 100%, but to at least 98, 99% chance that it's ruled out. And so We do think that there are people that just don't have the enzyme necessary to digest gluten. This is sort of like the people that are milk intolerant as opposed to the ones that are truly allergic to milk. Interestingly, it seems to be the same enzyme that's used to break down GLP-1, the DPP-4. So it's interesting. It'll be fascinating to see if it's something that does turn out to be more closely related to diabetes. Hepatobiliary disorders, stones, inflammation, hepatitis is the plural for hepatitis, and pancreatic problems. So cholecystitis is inflammation of the gallbladder. Cholelithiasis is just having stones. Most stones are predominantly cholesterol. There's some calcium in them as well. Estrogen tends to decrease the production of cholecystitis and cholelithiasis because the stones will usually pass down through. In fact, women do definitely get more stones, and there is the feeling that sometimes estrogens increase the risk of gallbladder stones. So, we do think that they are definitely related, and so usually those stones form in the gallbladder. The gallbladder duct dumps into the duct that is formed from the hepatic duct. That's known as the common bile duct. If a stone forms and then blocks that common bile duct, you'll actually have backup of bile into the gallbladder and the liver. Usually when that bile backs up, you'll end up with a bilirubinemia. Usually because it's conjugated, that's a direct bilirubinemia, as opposed to when the body is not producing the bilirubin quite so well in the bile, and that's an indirect bilirubinemia. Indirect bilirubinemia is very commonly associated with something called Gilbert's syndrome, which is just somebody who produces their bilirubin slower than usual. It's usually a benign variation. But if you have a blockage, those people will have high direct bili, high bili, and that blockage has to be cleared. So the hepatitis A, B, delta hepatitis only occurs with hepatitis B, hepatitis C, hepatitis E. We'll talk about hepatitis F, even though it probably doesn't exist. And then there's other non-lettered hepatitis. So hepatitis F, just to start with that one, we thought there was one. We had named it. We now are assuming that that doesn't really exist. So as of right now, there is no hepatitis F. Hepatitis A. So hepatitis A is ingested hepatitis. You have to eat it, usually fecal oral. It is definitely infectious, usually occurs in restaurants, and you have outbreaks. Sometimes it's associated with a certain vegetable. There was an outbreak associated with some bad lettuce or spinach a few years ago. There is a vaccine available. It's definitely a vaccine that you want to take if you're going to do any international travel. Very common in certain parts of the world, less common in the United States. State of Maine actually provides the vaccine for free. I'm not sure what New Hampshire does. So hepatitis B is a serum hepatitis. This is one that occurs in the bloodstream. Hepatitis surface antigen means you're infectious. Hepatitis surface antibody generally means that you're immune. Core antibody actually goes up in early infection and goes down in later infection when you're starting to be immune. There's charts that will talk about the various types, but basically if you're surface antigen positive, you are infectious. Delta or hepatitis D is a complication of hepatitis B and does not occur on its own. Hepatitis C, we test the antibody usually. There's no way to test for the actual virus in a extremely cost-effective way. So we do usually reserve that for people that are hepatitis C antibody positive. We actually do a viral load to see. Now, when somebody has hepatitis C, about a third of those people will fight it off and never have another problem. Naomi Judd is an example of that. A third of those people, it'll actually go chronic and turn into cirrhosis, turn into damaging the liver. And a third of those people will actually develop a liver cancer related to it. Now we have a very effective treatment. In the old days, a high percentage would go chronic, and they still will. But if they go chronic, we now have very effective treatments to treat 99% of those people. Hepatitis E is also known as A-like, so basically it's ingested, eaten. It's got a high mortality rate in pregnant women. It's usually only found in other parts of the world. People in the United States that get it would have probably traveled in either India, Southeast Asia, Mexico, or parts of Africa. So it's one of the reasons that we're not very familiar with it is because it's very rare in the United States. So pancreatitis, so itis meaning inflammation. Great question. I tend to do both amylase and lipase levels. Some people argue that just lipase is enough. Amylase is also secreted by the mouth, digestive juices that form in the mouth. But there are some surgeons that do both and can try to figure out the duration. No matter what, though, what happens is that if you get too high amylase or lipase in your bloodstream, it will actually start to digest the pancreas. It'll damage the rest of the pancreas. You may have stones in your pancreas. Alcohol may cause inflammation of the pancreas, probably in about half the cases, but that means half the case it's not. The other thing with stones is sometimes if you have a common bile duct stone, and it's way down next to the ampulla of Vater, which is where the pancreatic duct and the common bile duct both dump into the duodenum, then sometimes you'll actually end up with pancreatitis related to that. Sometimes pancreatitis is related to high triglycerides. So I try to keep the triglyceride levels below 300. We don't really think they're related to cardiovascular issues anymore, but we do know they're definitely associated with pancreatitis. The Ranson criteria for pancreatitis is all of these things. And so really this is, an inpatient issue and gives you an idea of how aggressive you should be. Pseudocyst formation, you can definitely have pseudocysts form. It is worrisome because pancreatic cancer, of course, is also very worrisome. The big difference is usually pain. Pancreatic cancer is almost always painless. Painless jaundice is usually a very ominous sign because if you have pancreatitis, you're going to have a lot of pain. Extreme pain and usually vomiting. If you have pancreatic cancer, you're not going to have any. And so once you get that CAT scan, if it looks like a pseudocyst, you're going to usually have had a history consistent with pancreatitis as opposed to consistent with pancreatic cancer. So exocrine pancreatic insufficiency is something that's being advertised on the TV right now. It's actually not something that we've talked about much over the years. I think we're going to have more and more patients coming in and asking about it, so that's why I did put a discussion question on the discussion board as well. Just to review, though, usually in people with exocrine pancreatic insufficiency, they'll have low B12 and folates, and you'll see the effects in the CBC, so usually they'll have a macrocytosis. Their red blood cells will be large. Iron levels will usually be low. The problem with that, of course, is that sometimes when iron levels are low, you get a microcytosis. And therefore, if you have someone that has an element of microcytosis and macrocytosis, their MCV may actually be normal, but there should be enormous variation in the size of their cells, and that's defined by the RDW, which I call the red cell distribution of width. Again, it's not exactly literally that. But basically, that's the standard deviation of how much variation is there in the size of the cells. So With EPI, you're probably going to have either macrocytosis, microcytosis, or a very high RDW. You're not going to have a normal blood count. Pro time may be prolonged, and so you need to check that in these people. They often will have low proteins and low cholesterols. You can check a stool test to see if there's evidence of pancreatic enzymes. Usually in people with EPI, their fecal elastase will be low. If you're unsure, there is a 72-hour fecal fat test, and these people are treated with a medication that includes lipase, amylase, and protease. Obviously, the drug company, if they're advertising, is making a fair amount of money on it right now. But if you're really unsure, you can refer them to GI. But if you've got somebody that's got a completely normal CBC, a normal pro time, a normal lipid panel, and a normal chemistry panel, the odds of them having EPI are very low. And especially if you then do a fecal elastase and that's normal, I think you can reassure those people that they don't have EPI. If they have doubts, you might have to refer them to GI, but unfortunately, this is kind of the flavor of the month. They're advertising aggressively, and patients hear it and they think that they might have it. So have fun discussing it on the discussion board. This concludes the talks for week 11, and I'll start working on week 12 pretty soon. See you on the discussion board.